Hey everyone, welcome to UCLA Health's Medically Speaking. I'm Dr. Eve Glazier. If you and your pillow are barely on speaking terms, if you've taken to comparing your sleep tracker stats with friends and coworkers, or your partner's snoring has its own soundtrack, these two episodes, Counting More Than Sheep, a deep dive into sleep health, are for you. In episode 1, we're going to talk about the science of sleep, why it matters, and how it directly impacts your physical and mental health. And then in episode 2, we've expanded our Asking for a Friend segment into a rapid-fire Q&A, tackling the questions filling up our social feeds, from doom scrolling and insomnia to whether it's a good idea to wake your sleepwalking partner. So let's get started. And joining me today is sleep expert Dr. Ravi Aysola, professor of medicine at UCLA's David Geffen School of Medicine, and director of UCLA's Center for Sleep Medicine. Ravi, thank you so much for being here today.
Great to be here, Eve. Thank you for having me.
Oh my gosh. Okay, we have a lot to talk about. Why don't we just start with basics? What exactly is sleep? Why do we even do it?
So this is the question that always comes up first, right? And it's a question that pretty much we talk about almost at every conference, and there's a lecture about it. Why do we sleep? You know, evolutionarily, all animals sleep. And it doesn't make a lot of sense. You're not reproducing, you're not feeding, and you're extremely vulnerable.
Yes.
So why is it conserved? And the short answer I give is it's the price you pay for having a complex brain. And if you want to have a nervous system and have a nervous system that's capable of doing all the things that our nervous system is capable of doing, it needs time to reorganize and rest, simply put. So that's why we sleep.
Yeah, it's perfect. And that makes a lot of sense because I think you're right. I think a lot of people are like, why would we even go offline? I mean, right, if you're in this vulnerable state, why is it worth the risk? So fantastic answer. And I also, though, appreciate that people are still asking it, though.
Constantly. Sleep often has not gotten a lot of attention from a medical perspective, mainly because it started off as a bunch of psychiatrists interested in dream research. And it wasn't until they started studying sleep and the advent of EEG in the 50s, and we started recognizing that sleep wasn't just the absence of wakefulness, but it was
EEG, I'm just going to...
electroencephalogram.
Oh, right.
Measuring the electrical activity of the brain. And when people were asleep, the assumption was that was just a downtime. And that's not the case. It's actually very tightly organized, and there are different stages of sleep that are unique in regards to the brainwave patterns, the muscle activity that happens, and what's actually going on in the brain and body during sleep. And so it's a very highly regulated process, and that really didn't come to medical awareness until, in Western medicine in the 1950s or so, when we started having tools to measure it.
That is so fascinating. I can't believe that until the 1950s, people were like, well, whatever, I'm just sleeping and talking and snoring. So you mentioned the sleep stages. That's exactly what I wanted to ask you. Can you walk me through the different sleep stages?
Absolutely. So, we've made some modifications to the sleep stages, but generally we categorize broadly into non-REM sleep and REM sleep. And REM standing for rapid eye movement sleep, which is based on what researchers at the time saw. Eyes darting back and forth under closed eyelids. In non-REM sleep, we break it down into stage 1, stage 2, and then now we couple stage 3 and 4 together. We just call them slow wave sleep. Stage 1 is kind of a transitional sleep. Often we do see some initial changes in the way the eyes are moving and the electroencephalogram, the EEG recording. But if we wake people up during that time, most of the time they'll say they weren't asleep.
Oh, really? And it's I just want to ask really quickly, it's this is the sequence. Stage 1 is like I get into bed, I fall asleep.
That's
this is
initially
stage 1. Okay.
Yeah. And then most commonly, next stage is stage 2 sleep. And this is what most people think of kind of as light sleep. And that's characterized by certain changes on the electroencephalogram. And then typically in the first half of the night, and this depends on a person's activity level, medications they're taking, and so forth, but generally, first half of the night, then we go into slow wave sleep. And slow wave sleep, stage 3 and 4, named because of the brain waves are larger and slower in frequency. And during that time, there's actually hormone secretion that's coordinated, most notably growth hormone.
Oh.
So adolescents will often have a lot of slow wave sleep because they're growing. People who work out really hard physically will get more slow wave sleep. And so it's not just important as brain rest, but also in coordinating growth of the body and hormonal timing. Yeah.
I actually had no idea that was happening. Yeah. So there's literally different things that are happening in each of these stages. So that's why they matter.
Yes, and REM sleep is actually quite unique in that. So the neurologists often categorize states of consciousness in kind of a hyper-simplified way. Is when we're awake, brain is awake, body's awake. In non-REM sleep, brain is asleep and the body is asleep. And then in REM sleep, the brain is awake and the body is asleep. And the reason they make that kind of oversimplification is that during REM sleep, our brain is quite active, and the EEG, or electroencephalogram, can look like someone who's awake. The difference is that muscle tone is inhibited, so it's almost like our body is preventing our muscles from moving, and so there's a voluntary paralysis, and that's predominantly when dreams occur, and during REM sleep. And REM sleep has been determined to be a key factor in everything from learning and memory, visual development, and it's also impacted by a number of things we do, including daily activities as well as medications we take. Some of the most common class of antidepressants, selective serotonin reuptake inhibitors, or SSRIs, actually inhibit REM sleep.
Really?
And that's been well known. And what's the impact of that?
Right. What are the implications of that?
Great question.
We'll be sure to come to the next sleep conference. So you mentioned that these are sequential. How do these cycles play out the night? So, for example, I go to sleep really early. I don't know if you're a night owl, but does it matter when you're going to bed or how long you sleep? The duration of, I guess, these cycles, or
that's an excellent question. So, let's assume that there's no abnormalities in sleep that are disrupting the sleep process. Then, in general, for most healthy adults, we cycle through those stages, somewhere 60, 90-minute intervals. The largest proportion of REM sleep, or rapid eye movement sleep, tends to occur in the early morning hours, right before we wake up. And that has some implications in regards to people's sleep patterns. And if a person is reporting sleep disruption, when in the night they're experiencing that disruption can give clues as to what may be going on. Right.
Okay, that's interesting. I'll have a lot of questions about that. I'd love to kind of hear from you, and I'm super floored that it's only since the 1950s that people have been talking about this, because we've been human beings for a long time.
Yeah.
But why does sleep have such a big impact on overall health?
So, in addition to kind of the neurologic processes for us to be able to maintain a very complex brain, oftentimes reinforcing things that we need to remember,
yes,
cutting off things and not reinforcing circuits that we don't need to remember are important, but also physical recovery, muscle recovery, growth. Whether it's growth in adolescence in overall size, that's why they tend to sleep a lot, but also in high-performance athletes. They need more sleep, especially if their muscles are being worked to the point of fatigue and requiring remodeling and so forth. So,
what if you're using your brain a lot? As that's part of a performance?
Absolutely. The exact dose of sleep may vary amongst individuals. Most adults between 6 and 8 hours.
Yes.
And I often say that we study sleep, and it's only into the 1950s that people have recognized that it's important. But for millennia we've known is critical, because all you need to have is a bad night's sleep, and we all know the consequences of that.
Right.
Everything from being irritable and mood effects to, if there's more significant sleep deprivation, impact on decision making, and especially in our studies and research in sleep and performance, it's really that executive cognitive decision making that gets affected primarily before anything else. And we know that from studying everyone from athletes to medical residents.
Right. Okay, good. So that was kind of my question. I mean, there's the athletes and then there's the mathletes. So I mean, right, so there's that component of rest and recovery, which again we could have a whole other conversation about, and we will. But I mean, what are signs and symptoms, that our sleep or lack thereof might be quietly messing with our overall health?
I think one of the most sensitive indicators of disrupted sleep is mood. Irritability, less tolerance for frustration. Often partners are the first to notice, a change there. With more significant sleep deprivation, most we hear initially is about nighttime disruption.
Yes.
I fall asleep okay, I wake up a lot, or I have trouble getting to sleep. It's not common that excessive sleepiness during the day is required to have a sleep disorder. Quite often, we encounter patients who have significant sleep disorders, sleep apnea and other issues, which are often recognized by a partner initially, and the individual themselves doesn't really have a complaint. They don't complain of being excessively sleepy. They're able to do what they need to do, at work. When we get into it in a little bit more detail, sometimes we identify that, there may be a fair amount of caffeine that's helping support their wakefulness.
Right.
That the performance that they're able to achieve is because of years and years of training and experience, and they've gotten very good at it, and it may be hard to detect impairment in those cases, and that's why so many sleep disorders go unrecognized for so long.
Oh, is that what you find?
Very commonly. I think the most common physiologic sleep disorder, and by that I mean that once a person is asleep, we see disruptions in the sleep process. The most common sleep disorders in that regard we see are breathing disorders, sleep-related breathing problems, the most common of which is obstructive sleep apnea. Ballpark 10 to 20% of Americans may have obstructive sleep apnea. About 85% are undiagnosed. And lots of reasons for that. One is awareness. People often think snoring and fatigue in middle age are attributable to having kids or a tough job.
Or they've normalized it,
And that's what it is. And individuals don't have any frame of reference. They don't know what it's like otherwise, because that's all they've experienced. So in those cases, we usually, as sleep physicians, see patients once a partner complains or a primary care doc recognizes that there's other problems, high blood pressure, that's going on. And especially in younger individuals, I'm very heartened to see our primary physicians asking about sleep more and more. And when they identify an issue, snoring, frequent awakenings to urinate, which is probably the most under-recognized symptom of sleep apnea, then they've been much more attuned to testing and or referring for us to take a deeper look.
Wait, that's so interesting that you're mentioning the frequent urination. We had Dr. Chris Seigel on, right? And we talked about when prostates get enlarged and men, get up a lot to urinate during the night. And you're right. I mean, I'm a primary care doc, and my mind first would go to, oh, well, it's because your prostate has, gotten larger over time. I will say, that most primary care docs, we always ask about sleep. It's part of our, review of systems, meaning, we go through every sort of organ system and say, how are you sleeping? So, but that's good to know. And I do want to get to, when to refer to a sleep specialist like you. I want to back up a little bit because you mentioned high blood pressure. So I guess that's the question about, maybe you could connect some of those dots for us, which is, how does, I guess, chronically lousy sleep or suboptimal sleep, again, whether it's caused by, frequent awakenings, breathing, how does that raise the risk for certain medical conditions?
That very good question. And I think, the most evidence we have in regards to this risk is related to sleep-related breathing problems. And just for a moment, I just want to pause for a second and say that right now, we treat really obvious problems. People who don't breathe right at sleep, when they're asleep, and their oxygen levels drop. When we do sleep studies, it's not subtle. We see people's breathing disrupted. There's no airflow. Oxygen is dropping from 90s, sometimes down to the 80s, 70s, 60s, dangerous levels. And, when I give lectures to the trainees, the medical residents and students, I show them an example of what we see on a sleep study. And I say, if this person was awake, they'd be in an intensive care unit. But this is happening every night, 20, 30, 40 times an hour they're having disrupted sleep and a drop in oxygen.
That's a really profound way to frame it.
Yeah. And so when that's happening, the body is not actually responding to a drop in oxygen. What it's responding to is a lack of the chest moving or of breathing when we're making effort. So it's actually collapse of the upper airway, the tongue and other soft tissues in the throat, that when they relax, partial collapse of the airway causes snoring. That's the vibration. But when it collapses to the point where airflow is compromised and oxygen levels drop, that's when we call it apnea. And we define severity on how often that's happening. The lower the oxygen level drop, the more frequent the episodes, the more the brain is waking up with a stress response. And with that stress response, which is a reaction to, wait, I'm trying to breathe, but no air is getting into the lungs, there's an increase in blood pressure, an increase in kind of the stress response, so increased cortisol and other hormones. And that all causes an increased demand on the heart. It's having to pump against a higher blood pressure. It also may be having to do so in the setting of lower oxygen levels. So simply put, untreated sleep apnea is stressing the heart every night.
Right.
And
it's like these micro traumas.
Exactly. Yeah. And over years and years and years, that's how it contributes to high blood pressure and risk of heart disease.
Not to mention if you're waking up, gasping, and feeling the stress, it's awfully hard to go back to sleep.
It is. It is. And that's part of some of the challenge in identifying this. We can get to this when we talk a little bit more about insomnia, but sleep is going to happen no matter what. Okay, so the best example I have of that is I show some of my insomnia patients a sleep study of someone who has really bad sleep apnea. This person cannot breathe when they sleep, but the brain still sleeps.
Oh, interesting.
Because of the need to sleep.
Right.
So even though the sleep is disrupted by such a fundamental abnormalities, not being able to breathe, sleep still wins. It ultimately, even though there's that disruption, the person goes back to sleep.
Really? The sleep mechanism will prevail?
Will prevail. And they may or may not be aware of these awakenings, and they may be only something that we detect on a sleep study, and we refer to them as micro-arousals. It's just enough awakening for the body to restore wake muscle tone in the airway, so breathing is normalized. So then oxygen levels normalize, everything looks good for a few seconds, and they fall asleep, and the cycle repeats itself.
Okay, got it. So this makes sense, too, for me as a primary care doc, because sometimes when I'm talking to patients, they don't self-report. They're not like, I don't think I'm waking up gasping. But when we're talking about other things, they say, well, I am maybe sleepy during the day, or I'm having like headaches all day long, or my blood pressure is up. So this is kind of upstream maybe of the symptoms I'm seeing.
Absolutely. The most common complaint we get from people with significant sleep apnea is, Doc, I fall asleep okay.
Yes.
I wake up more than I think I should, and I don't feel rested.
Right.
That's it.
I don't feel rested.
That's it. It's not, Doc, I'm waking up choking and I'm struggling to breathe. Very rarely do we hear that. Most commonly, it's just I wake up and I don't really know why. Yeah, I get up to urinate several times, but maybe that's my prostate.
Right.
And so it gets kind of muddy.
What I especially like about what you're saying, though, is that let's not normalize any symptom, right? Like, let's not wait for the most dramatic description, right? Of, it's almost like heart attacks, too. Everyone thinks that a heart attack is going to be like this, elephant on your chest. We already know for, women, they have different symptoms. But even for, for sleep disturbances, right?
The example you give of the heart attack, I think, is critical, because we had to train people. People's hearts are here in their chest.
Yes.
But jaw pain down the left arm is not intuitive as your heart.
Indigestion,
yes. Nausea. These are things that we had to educate the public about as clinicians and care providers. And now it's kind of common knowledge. If you've got jaw pain and pain shooting down your arm, that could be your heart. We need something similar for sleep, and for that message to get out, that it's not normal to wake up multiple times a night or with heart racing, or to wake up with headaches, or to feel fatigued all the time despite getting an adequate duration of sleep. 7 hours is kind of the magic number that often falls out. So a lot of what I do is education. And that's, really, as a pulmonary critical care sleep physician, treating the breathing problems is pretty straightforward.
Yes.
It's not medically complex. What is more challenging is getting people to understand the connection between what's going on at nighttime when they're asleep, and how that may be affecting their ability to do the things that they want to during the day, and also affecting their longer term health.
Yeah, and it matters so much. And you mentioned mood as being, one sign, right?
Yes.
As maybe getting suboptimal sleep, or right,
Yes.
or that's short on sleep. I'd love to hear a little bit from you about how good sleep, you talked about growth, but how good sleep, right, or lack of, but how it affects learning and memory.
So definitely in the growing kid, and I've got growing kids, so paying a lot of attention to this. Sleep is absolutely essential, both to behavioral issues.
Yes.
Oftentimes sleep disruption in younger children, whether it's due to apnea or other causes, results in behavioral problems. Hyperactivity often is a consequence rather than excessive sleepiness. In regards to memory retention and so forth, absolutely, it's critical. And one of the slides I often show when I give talks, and this is a comment I make to all my trainees: please read the lay literature first before you read the medical literature, because that's what your patients are reading.
That's right.
And they're going to come in and ask about that, not what was published in, your specific scientific journal. Now, one of the big publications, I'm a big fan of NPR, there was a publication about on a study that was done in the UK about healthy habits to reduce the risk of developing depression. And they had 7 healthy habits, and the one that was most impactful was healthy sleep. And that, I think, is not really shocking, because we recognize that if something is wrong with us emotionally, in our ability to handle or manage stress, or physiologically we're not feeling well, we're ill, sleep is often the first thing to get affected. And so it's not necessarily shocking that if you sleep well, you're going to overall be healthier. We talk about it; it's in our language, right? Can you sleep well at night? Are you okay with the decisions you've made morally to this day? And so it really is a global marker of health.
But what is healthy sleep? Because I have to say, sometimes I feel scolded, right, by, let's just say, the internet or life, that I'm not sleeping. I want to sleep healthy, right? But there's this aspect to sleep that feels sometimes a little bit beyond our control. Like, I woke up at 2:30 this morning. I would have liked to go back to sleep. So let's talk. What is healthy sleep?
I think you bring up an absolutely wonderful point there. Trackers.
Okay, yes.
Everyone and their mom has a tracker of some sort that purports to measure sleep. It's also a topic that has come up at every conference for the last couple of years.
Good.
Mainly, which one of these have been validated against gold standards, and very few have. Most are probably internally consistent, one presumes. But fascinating diagnosis that we have now made is called orthosomnia. Orthosomnia is the problem that patients come in with, worried about their sleep because their tracker is telling them that they're not sleeping well.
Yes.
And so they said, my tracker didn't show that I didn't get enough REM sleep, or I didn't get enough slow wave sleep. What's going to happen to me, doc? And this is a challenge because we're dealing both with wanting to treat any physiologic cause of sleep disruption, recognizing that those are all connected to psychological causes of sleep disruption. We talked earlier about how when you sleep, it's when you're most vulnerable. It's also when ideally there's fewest distractions and it's quiet. So it's a perfect time for all the worries of the world to flood your mind and for you not to have a way to put it away. That's often why people reach for their phone and doom scroll, play a game, something to distract them, hoping that whatever may be stressing them, and preventing sleep will dissipate. Ultimately, that may happen because the lack of sleep results in the need for more sleep. It's a homeostatically regulated, meaning that the body compensates for lack of sleep by making you more sleepy. So ultimately, like I said earlier, it wins. But we then start developing a pattern.
Yes.
And then that pattern becomes one where people start saying, I don't sleep well.
Right. Or I keep waking up at 3. You get quickly habituated.
And then what happens is this goal of, if I don't sleep well, the first thing most people may do is try to spend more time in bed. Get in bed earlier or stay in bed longer, hoping more time in bed equals more sleep. It doesn't. More time in bed equals more time in bed, getting frustrated that you're not sleeping.
Right.
So it really reinforces that behavioral association of sleep and stress. Add to that this perspective or belief that I don't sleep well. And it becomes a very powerful self-fulfilling prophecy.
Right, you identify with.
You go to bed, I don't sleep well. You do the behaviors that interfere with sleep, so you don't sleep well, and you prove it to yourself night over night over night. And you've done that for years. It then becomes more challenging to unravel all of that. So one of the things I say about insomnia is normal. Pause for a moment. Occasional.
I'm letting that wash over me.
Yeah, occasional insomnia is normal. Because it's in our language, right?
Yes.
Stuff that keeps you up at night.
Yes.
Right? It's there. Stress is part of life.
Yes.
It's going to impact you. There's going to be nights where you're not going to be able to sleep for whatever reason, or sleep well. The goal is that we don't want to start a pattern where that becomes every night.
Right.
The goal is, okay, I had a bad night of sleep. But if I stick to the plan, consistent wake times, good, what we call sleep hygiene, getting off the screens, minimizing light exposure.
Love it.
It's not staying in bed, getting, when you're not able to sleep. These types of things. If you stick with that plan, the hope is that, okay, one night of insomnia, maybe 2 nights of insomnia, but very rarely more than that, because the sleep deprivation that accrues from one night of lack of good quality sleep will be made up on the subsequent day or the day after, because that sleep deprivation promotes more sleep. Very easy for me to say, very hard to kind of accept, and to the point where you're actually going to change your behavior.
But I appreciate you saying that it's, that it's normal, meaning that not having a great night of sleep is normal. It's a little bit, tell me if you agree or don't, but about feelings of anxiety and depression. It is normal to have feelings of anxiety and depression, to feel stressed out. But when it becomes debilitating, when it starts affecting your relationships, right? Your mood, your memory, your work, that's when, right, let's go get some help. And I think this is helpful when we talk about insomnia. And you can tell me if I'm wrong. I'm guessing it's one of the most common sleep problems.
Absolutely.
But when it becomes something to worry about.
Yeah. It's, I think you hit the nail on the head with the term when it becomes something to worry about. And as an ICU physician and a sleep doc, I often compare and contrast as people say, how do you, or how did you do both? In the ICU, your sickest patient takes up most of your time.
Right. And in ICU is intensive care, right?
Care,
the most sick.
Most sick patient takes up most of your time. In the sleep clinic, often our most sick patients are people who have heart issues and breathing problems. They're actually pretty straightforward if we treat the breathing problem. The patients that take the most time are the worried well, or those who have insomnia.
Right.
And an example would be a person coming in saying, Doc, I'm not sleeping well. And okay, we talk about what's going on in their life, things that may be stressing them out. And it's not uncommon for me to hear, no, Doc, I'm not stressed about anything. My life is great. My kids are fine. Finances are fine. Work is fine. I just can't sleep. And I was like, okay. So what is it that is stressing you out? The lack of sleep.
Like
if I could just get sleep, then everything would be okay. And that desire to achieve sleep, often which goes along with certain personality types who are not comfortable tolerating discomfort and would rather fix it.
Yes.
Are predisposed to that situation. So often the conversation I try to steer towards the understanding that sleep is not something that we have to try and do. Sleep is something that happens on its own when we remove the obstacles that are preventing it, whether that's behavioral or physiologic, meaning breathing problems.
Sure.
Again, very easy for me to say.
Yes.
Very hard sometimes for people to take in and then implement into practice, which is often why with insomnia, we rely on our psychology colleagues to do behavioral therapy and cognitive therapy, really to talk through beliefs that are maybe inaccurate or things that may mislead individuals to put too much emphasis on things that they cannot control.
Well, it's interesting, right? Because you spoke at the beginning about how sleep was the whole, enterprise of sleep was originally studied by psychologists, right?
Psychiatrists, yeah.
Psychiatrists, and certainly, right, dreams and sleeping. So clearly, sleep does not exist in a physiologic, right, one body, mechanism. So it's maybe, you mentioned cognitive behavioral therapy for insomnia. Maybe we could talk a little bit about your approach then to a patient, whom you've diagnosed with insomnia.
So, what I find is that there's a lot of information out there in the world and a lot of, I think, conflicting information and sometimes misinformation. So I've kind of distilled things into kind of 4 simple rules that I generally recommend across the board. And I mention these because a lot of people's sleep will improve just by implementing this and understanding that. And first and foremost is wake up at the same time every day. Okay. Consistent wake time.
So use an alarm if need be.
If needed, yeah.
Okay.
And an extra half hour on a weekend, so forth. But what we want to avoid is I slept in an extra 3 hours on Saturday because I don't get my sleep other days. Second rule is don't go to bed until you're sleepy. And this is to try to avoid that time spent in bed nesting, doing other things, looking at your phone, doing work, perhaps even eating. The bed starts to take on other roles when people are trying to increase their sleep by spending more time. So what I say is we want you, don't get into bed until you're really feeling sleepy.
And you're ready to go to sleep.
And you're ready to go to sleep. So often I hear patients say, bedtime. I'm really consistent about bedtime. I get in bed by 10 p.m. every night. I'm like, are you sleepy at 10 p.m.? No. So what's happening?
But I think people might be, tell me if you encounter this, people might be retreating to their bed or bedroom for their relaxing time.
Absolutely. And it's often to shut the noise and the light, actually, that we're constantly inundated with. Unfortunately, that relaxing time often involves another form of light,
right?
The handheld,
right?
And so,
or light from a TV, right?
The TV, and so, in addition to the don't go to bed until you're sleepy, don't stay in bed trying to sleep. And that's to, again, uncouple that frustration that goes along with struggling to make yourself sleep, which doesn't happen.
Does that go for at bedtime and if you wake up in the night?
And if you wake up in the night, generally what I give people is I don't strictly give a time limit. I don't want them watching the clock. But most people know, I woke up, am I going to get back to sleep? If they don't, they have that kind of internal threshold that they hit. It's not happening. If that hits, get out.
Okay.
Because we want to uncouple it. And then we want to decrease light at night. And this is the hardest thing, right? All of us are prone to, looking at phones, TVs for relaxation, to catch up, whatever it may be. And really, I think last time I looked at the number, something like 80% of humans on the planet are exposed to way more light than we were ever evolved to deal with, right?
Fascinating,
And so it really requires effort to decrease not just kind of the signals that we're constantly getting, but the way in which we're getting those signals through the mediums, through light and through screens and so forth, because that's activating.
Right.
And that light is the factor that has the most profound effect on our circadian rhythms, so our rhythms that are related to kind of the natural day or cycles of the earth. So when we're exposed to excessive light, that tells the brain to wake up, and it tells the brain to not make melatonin. And so when we're doing that, it really interferes on a multiple levels, very much on the kind of cognitive thinking side of it, but also on hormonal control, because melatonin's a hormone. So it really messes, I hate to say this, but it's the truth, is our culture. Is really aggravating to our sleep problem, and that's why it's, an epidemic, so to speak.
No. I mean, and thank goodness you're raising awareness about it. Yeah. Can we talk a little bit more specifically about the light then? So, you're saying get into bed and when you're tired, right? So not to sit there and scroll. Is that correct?
Yes, absolutely.
And limiting, right? So kind of the screens. Right. So, but just about light in general. I mean, so does the bedroom or where you're sleeping have to be a certain,
that's a great
level of blackness? Like, should everyone have blackout curtains?
In an ideal world, yes.
Oh, okay.
But also, there's safety issues, right? If people are getting up for other reasons and there's balance problems or otherwise. When it comes to light, the wavelength matters.
Okay.
So blue light is going to be more alerting and activating.
Is blue light what's coming from the phones?
It often is. Sometimes there's apps or features on the phone that say they limit blue light, including glasses and so forth. My perspective on that is, if you're dealing with a problem like insomnia, then just take it out of the equation rather than try to come up with some kind of mitigating factor. That being said, and we see this often in the hospital now, where there's much more attention to trying to maintain an individual's sleep quality to the extent that we can in that setting. You'll see nurses with red lights going in, and they have the headlamp with the red light, and it's enough to see, but that red light is less likely to activate the brain when we're exposed to it. So
wait, that's fascinating. Is that happening at hospitals all over? That's like the gold standard?
I don't know if I can't say if it's a gold standard. I'll say it's certainly happening in the last few years, especially I've seen, at the hospitals I work at, where there's been
and in ICUs.
Posters up and everything up saying, hey, we need to promote sleep, so let's not go in and do unnecessary testing or blood draws at 3 a.m. Let's let the person sleep.
Right, because I'm sure it promotes healing, right? And rest.
Absolutely,
yes.
absolutely.
Oh, wow.
And in the
incredible.
ICU, sleep promotion can reduce delirium and confusion and just losing track of day and night, which often happens to people in the hospital, can really aggravate problems, cognitive problems and delirium or confusion in the hospital. So I think, those of us in the sleep world have known this for a while, but it's really kind of, I think, gotten through to the general hospital administrators as well, who really recognize that we need to structure care that respects sleep.
Right. And we also have done an episode with Dr. Ashley Busatil, who's a hospitalist, and we talked about quality, safety, and outcomes. So outcomes meaning how people do. I will ask you, but I'm guessing that patients do better, right, when they sleep better during a hospitalization.
Absolutely. The challenge is we don't have lots of tools to promote better sleep yet. Most of what we do is to try to avoid interfering with that and just set the environment, in such a way that it's more conducive to sleep happening rather than disruptive. I think a lot of the way, especially when I trained, the schedule of medicine was based on the physician needs, not based on what was best for the patient. And this is an area it's really fascinating because it has not just to do with sleep, but also our circadian rhythm, our 24-hour kind of biologic rhythm as it relates to our environment in the sun. Outcomes in regards to everything from cardiac surgery, what time of day you have cardiac surgery, what time of day you're getting certain types of chemotherapy can actually influence the effectiveness of those therapies and the safety of that therapy. And that's an area that I don't think many physicians recognize, but we're just getting to the tip of that. And there's a few great examples that we have, but we're at very much the tip of the iceberg of understanding how time and our circadian rhythm impacts the efficacy of our treatments.
Wow. Yeah. And you mentioned environments, and we were talking about an environment, right, like in an intensive care unit in a hospital. But just going back to, I think, the bedroom setup, right? So we talked about light, right? When to get into bed, when to get out of bed. What about, I guess, white noise comes up or brown noise comes up or frequencies, but also the temperature of the bedroom is something I want to ask you.
Great questions. So we all sleep better when the temperature is dropping, because that's kind of what signals all of us that it's nighttime, right? Where most of us have our primary sleep period. Sounds, generally low frequency, kind of repetitive, think Gregorian chants or something along those lines that can, and brown noise or white noise, something that drowns out other distracting noises can certainly help. I've heard from patients that a familiar opening to a sitcom, is kind of reassuring. Something they've heard or seen a million times is just okay. And, sometimes it's a negotiation about what we're going to try and change. And my goal there is just, have the screen turned in a different direction or wear something to cover the eyes. The auditory stimulation is okay if it's not grabbing our attention.
Right.
Sometimes the problem with listening to a show or something that is intended to grab our interest is that it'll do that even if we're asleep. So we don't want activating. So something dull, monotonous, maybe repetitive, familiar, may be okay. Temperature dropping helps.
Is there a magic number for the temperature? Like if you have the privilege of manipulating your bedroom environment?
I don't know if there's an actual magic number. I will say that, one of our exceptional researchers, Jerry Siegel, had an article several years ago that was picked up regarding sleep patterns in non-industrialized societies. So sub-Saharan Africa and Sub-Saharan Africa and some tribes in South America. I think the tribe in Africa was the San, the San. And what he noticed is that people did not have a uniform bedtime or sleep time. That tended to vary a little bit. What was much more consistent was wake-up time. And that wake-up time varied also depending on the season and was very tightly linked to temperature. So when the temperature was dropping, everyone's getting to bed. As it starts to warm up, and the sun's coming up, people start to wake up. And our internal body temperature is also not constant throughout that 24-hour period. We actually hit the lowest body temperature, or a core body temperature nadir, typically a couple hours before we wake up, 2 to 3 hours.
Is that tied then to the REM?
That is tied to the fluctuations in our thermoregulation, not necessarily distinctly with REM. Yeah, mostly with kind of our body's cycle. And, it made sense to me when I learned this of why everyone got cold on call at 3 a.m. and everyone, the temperature in the hospital didn't change at all, but everyone's suddenly reaching for blankets and putting on warm stuff because physiologically that's when our temperature hits the bottom. And that's actually something we use experimentally to characterize a person's circadian rhythm, is when do they hit their lowest body temperature, and then when does their body start making melatonin. So these are the kind of things that we use.
So would it be helpful to take a hot shower before bedtime?
That's a great question. And the reason the hot showers help is because of the change in temperature that occurs after you get out of a hot shower to the environment.
To the core temperature, your core temperature.
Yeah, and that delta, that change from that warm temperature you had, skin temperature and surface temperature that you had when you were in the hot shower or bath, to what's happening when you get out and that temperature dropping is a signal that reinforces bedtime.
Interesting. Yeah. Okay, so let's talk caffeine and alcohol.
Okay.
Because I think a lot of people, and I'm sure I'm not the first person to say this to you, right? They're like, I have a couple glasses of wine that makes me feel sleepy. And I fall asleep, but then I wake up at like 2 a.m. Tell me what's happening.
Alcohol, central nervous system depressant. Yes, it will make you drowsy and make you sleepy. As it's metabolized, it interferes with the sleep process. So people, especially as I get a little bit older, will often comment that I used to be able to have a glass of wine, with dinner or afterwards and go to sleep and have no problem. Where with time, they're starting to notice I'm starting to wake up and I don't know why. Yeah. And it could both be the alcohol effect or the indirect effect of disrupted breathing. That's worse when you're alcohol. The muscles are more relaxed. If someone is prone to sleep apnea, it's going to be worse if they have alcohol in their system. Okay. We encounter a lot of patients who have gone to alcohol as to help their as a treatment of their insomnia.
People get desperate to sleep. Sure.
Absolutely, and it is probably the most commonly used substance to try to help promote sleep. But paradoxically, even though initially it may help you get to sleep, it's actually really interfering with it, and interfering with kind of the normal sleep cycling that's going on at night.
And what about caffeine and its effect on the sleep cycles?
Yeah, caffeine, certainly is a stimulant and keeps people up. Now, I've certainly heard people
have so many different responses to it. Yeah,
that's exactly what I was going to get to. So there's multiple variations on the genetic variations in individuals' susceptibility or sensitivity to caffeine, how they metabolize it, and so forth. So some people who say I can have a cup of coffee and go right to sleep later on, no big deal, and there's some truth to that. And others who say if I have any caffeine, I'm not sleeping at all. What I often suggest is that people be aware of the dose of caffeine that they're getting. For example, most drip coffees that you would get at, the kind of commercial coffee stores, probably have somewhere on the order of 300, 350 milligrams of caffeine. A shot of espresso somewhere between 60 to 90. Oh. And people sometimes are surprised by that. So I have people who are, addicted to their drip coffee. As we're trying to maybe taper that off, I get an Americano. You're actually getting significantly less caffeine that way.
Interesting.
And now, apart from coffee, all the various energy drinks and so forth. In my presentations and educational talks, I always share a slide about the most common consumables and the caffeine dose, because I think like anything, it's important to know what you're putting into your body.
Yes.
Modest doses of caffeine can improve performance, actually, and can certainly help with alertness. I think the key is we don't want to use it to compensate for inadequate sleep. And you bring up an interesting point of the caffeine and alcohol, and something that I've noticed over the years is that people are often self-medicating on both ends.
Yeah.
Caffeine to help kind of get them up and going, and then alcohol to kind of help, drop them back down. And really,
those are the amateurs, right?
Yeah.
The professionals are taking, medications, sleep aids, and then they want other prescription medications to up them. I mean,
right.
We can have a whole conversation.
And it's, this area of, I'll sleep when I'm dead kind of attitude. And so I need to minimize my sleep and optimize my performance, and anything that's going to help me do that. Caffeine is beneficial.
Yes, just this performance-driven, talk about culture.
Yep. And I'll sleep when I'm dead was, the phrase, right?
Yeah.
And I think we are continuing, and I often see a lot of research focused on, well, how can we kind of game it? And the kind of conclusion I come back to is that's not the point.
Right.
We're not trying to game sleep.
Well, that's why I like talking about the evolutionary sort of like purpose. And even if there's more to be found, like we are human organisms, right? We are mammals. I mean, I'm so fascinated by, there's a reason why we sleep. There's purposes. There's
actually a study done by one of our pediatric sleep researchers who looked at educational outcomes and degree of wellness that school-age children had. Noticed that the kids who slept less had higher performance in their academic achievement, but lower scores of wellness.
Right.
And the kids who slept longer had higher scores of wellness.
Yes.
And lower scores in academics.
Right.
Which I think is a comment on society.
Well, it certainly is, and priorities. And then also, like, that's at this point in time, right? So these are school-age children. How does then, I'm guessing, I don't know if that research study exists, but how does that then play out, right? As you're a later teen, an adult, et cetera.
Yeah, and then we struggle with so much mental health issues.
Yes.
And in a society that values productivity and performance at the cost of maybe health.
I'm so excited to do this walk with you. Bring back sleep. Sleep happens. I'm going to get all the t-shirts made. I want to spend a minute on, we talked about insomnia, and I just wanted to spend a minute on another very common sleep condition, sleep apnea. And you mentioned obstructive sleep apnea, but especially in the context of what you do as a sleep specialist. So I'm a primary care doctor, as everyone knows. I say it constantly on this show. And so, whether someone refers themselves and says, oh my gosh, my tracker is telling me I'm not sleeping well, and I'm going to go see Dr. Aysola as a sleep specialist, or whether I, during a annual physical exam or visit, am talking about sleep and some of these things have come up, or I say, gosh, why do you have this, high blood pressure that's not well treated? Why are you sleepy all day? Or your partner is talking about you snoring all the time, and then I refer them to you. What happens when someone goes to a sleep clinic? Or gets a sleep evaluation?
That's a great question. Yeah. So, we certainly take a thorough history, and I won't diminish that, because I think these days most medical schools get an hour lecture on sleep. And so how to take a sleep history. Are you sleeping well? And the answer is no.
History means you asking lots of questions.
What's the question you ask after that? So that's what we really get into. When we start talking about sleep disorders, how I often frame it is the only reason I see to treat sleep problems or any problem is because of symptoms or risk to your health.
Right.
One of those two things.
Okay.
And those are the reasons why we see patients. And it's one of those two things that are often the reason for referral. Either the physician is concerned about a health risk or a symptom, or the patient is concerned. And
all good reasons.
And all of those there. And so when it comes to sleep apnea, one fascinating issue is that the symptoms and health risks don't track together, meaning that I commonly see younger patients, 30s, 40s, complaining of disrupted sleep. Their partner tells them they snore, they wake up a lot, they really struggle to function, and we end up doing this sleep study and testing. and they end up having very mild or even borderline sleep apnea. We treat it, and they feel remarkably better. In contrast, I often see patients in their 60s, 70s, perhaps, sometimes older, brought in, to clinic with the partner complaining, this person sounds like they're choking every night, and I got to elbow them because I'm worried. And the person is sitting there looking at both of us saying, I don't know why I'm here. I'm here because my partner is complaining. I feel fine. That is quite common. And why that is a great question. We're still trying to understand why some people with sleep apnea are sleepy and others are not, and the impact in regards to daytime experience or nighttime sleep quality experience, why that varies. One of the things I think is the biggest point when I see patients is to identify people who are at risk for sleep apnea, who often go unrecognized. And most people understand that if you're an obese, middle-aged man that snores loudly and has high blood pressure, okay, sleep apnea may be playing a role. But especially in women, the pattern of apnea is different. Women's risk of apnea increases significantly after menopause. The risk of apnea is not just related to weight, it is also related to upper airway anatomy, the relative size of the jaw, the tongue, and these things are not static. It also depends on the position you're sleeping in or the stage of sleep you may be in. One common finding that I share is that postmenopausal women, especially of East Asian origin, are higher risk for sleep apnea. And people of East Asian origin may be at higher risk of apnea, less related to obesity, meaning that I see a lot of postmenopausal women who are of East Asian descent who have very low BMIs, body mass index. They're very thin. And physicians, others may not think about sleep apnea as something that's playing a role in this patient.
Or they're dismissing that maybe their sleep issues,
your
hormones are off,
Exactly. And certainly with menopause, hormones,
it just
that's one of the roles.
complicates the whole picture.
But I think it's important to include this as a consideration because it can often be very impactful into improving quality of sleep, as well as reducing risk of things like everything from high blood pressure to stroke risk, especially in women.
This is so great. We have so much more to talk about. What we're going to do is we're going to take a very quick break for a nap after you tell me exactly what the magic number is for my nap. We're going to come back. When we come back, we're going to have a rapid fire kind of Q&A and just continue our discussion. And I'm also going to ask you kind of what has gotten you into sleep medicine, because I know that you have a background in pulmonary medicine and critical care. And I want to get into that a little bit if that's okay.
Sure.
So we'll just take a very quick break. To everyone out there listening, thank you for joining us. Next up, we will have a lot more coming. So thank you very much.